All right, excellent. Good evening, everybody, and thank you for joining our first Molteno3 webinar. My name is Joe Bankovich. I'm the president at Nova Eye Medical. Brief history of Nova Eye Medical, because there is a brief history only. July 1st, Nova Eye Medical became a new company after a spin out. We took the eye track product from the company formerly LX, and we spun out to be a standalone organization. And we didn't rest too long on our standalone laurels. On July 2nd, we purchased the Molteno product line and the factory in New Zealand. So for the last 3 months or so, what we've been doing is we've basically just been transitioning. Katina used to sell this and marginally sell it in the US. And so we've been taking that over, doing a deep dive in the science and trying to understand this product. So we're very excited about this product. It's a very, very small footprint in the US. But what we do know is this: it's one of the newest GDD technologies in the US that's not just a replication or a copy of another product. It has its own unique science behind it. It's the #2 product in the rest of the world. And if you look at this product, it took off from the last 50 years. Professor Anthony Molteno, this is basically his love child and the work of the last 50 years of his life to get to where we are right now with this product. So the best part to me of buying Molteno was when I looked at the current US users, there weren't a lot, but every one of them were people that I considered my friends. And one of the first names I saw was our speaker tonight. So it was really just an added bonus to get Dr. Singh actually working with this product already and having a 6 or 7 year history with it. So for those of you that don't know Dr. Singh, but I can't imagine there's anybody, Dr. Singh is a Duke fellow. He practices in Kenosha, Wisconsin, and he will explain to you where Wisconsin is for those of you that don't know. It's in the middle.
Yeah, I mean, people like George Tanaka in California, they don't know where Wisconsin is.
Yeah, but he's in Arkansas now. But he knows now.
He's back in San Francisco, though.
Oh, I did not know that. Okay, so he's a leader in MIGS. He's one of the first people to do eye stent, one of the first people to do Durista. He's a leader in all of glaucoma. And as you heard earlier, we're just lucky that he's a failed rock and roll star and had to get a job and ended up in glaucoma. Otherwise, things could be a lot different. So, Dr. Singh, thank you very much, and I'll pass this over to you.
All right, thanks, Joe. I appreciate that, and thank you, everybody, for hanging out. I know it's late for some of you, and those of you who have other things in life to do, I appreciate that too. We've been zoomed out, I think, for the last 6 months from pandemic, so I'll try to keep it as interactive. And I know a lot of you on the line, so it's great to see a lot of familiar faces. So thank you again. Let's keep it interactive. I mean, everybody on the call here, I think, is experienced glaucoma surgeons and use tubes and drainage devices as well. So I love to kind of have like a users meeting about glaucoma drainage devices in general, because look, there's such a nuance to how we manage it post-operatively, when do we stop drops, how do we manage the hypotony stage and hypertensive phases and all this stuff. So please feel free to kind of open up, chime in. This is not meant to be a lecture per se, but I will say it's cool that Nova Eye is doing this, because I've been, as Joe mentioned, I've been like this kind of like MIGS man for so long, MIGS, and drug delivery and SLT, and I believe in that, no doubt. But there's every once in a while where you're like, thank God I have a tube. We need this tube, and so there are moments in my life where I forget that I'm a glaucoma specialist, and then there's moments where I'm like, why am I a glaucoma specialist? Because I do too many tubes all day long. And so I think it's important to kind of have this discussion again, reinvent and rediscuss kind of the importance of glaucoma drainage devices as well. So we're going to go through some of the nuances of the Molteno3. As Joe mentioned, I've been using it now for the last 7-8 years. And in fact, I was one of the few people using it, many years ago, and people were like, they're using the Molteno? What's that? Wasn't that like from 40 years ago? It's not the same one. Don't worry. There's some changes. There's some differences. And we'll talk about that. Well, based upon our political environment, I'm from Wisconsin. It's not a blue state or a red state. It's a green state because we're Packer fans. So I have actually a cheese head that fits over my turban that my parents gave me, so I would never forget my roots as a Packer fan. But I do live, though, in Illinois. So right now I'm talking to you in Illinois, a suburb of Chicago called Lake Forest. And I know Chuck Yang's on the line, so he knows where Lake Forest is. But I'm still a Packer fan. No, I can never convert to a Bears fan. So I'm always going to be a Wisconsin cheesehead fan all my life. But it's good to be here. And I want to ask you guys, what do we want from our implants? What is the goal when we say, here's the implant that's perfect for me? Well, obviously we want efficient surgery. We do know that can be a pain in the butt to get under the muscles, especially if you're using, like a barbell, let's say. Worrying about dissection can be difficult for some people. Keeping that plate suction cup to the scleral wall because it wants to ride forward sometimes. And how do you suture it down? I mean, these are all things that we deal with on a day-to-day basis when we're performing surgery. And then of course, we always want to deal with, don't want to deal with rather all the adverse events that happen post-operatively. Obviously, hypotony with non-valved surgeries like the BAERVELDT as well, and now with the ClearPath that came out, these non-valve procedures, we do have a risk of hypotony when that vital stay suture opens up. And how do we deal with that? And we don't want to deal with that if we don't have to. Telling patients at 6 to 8 weeks, don't move, don't do any kind of hard work or labor, stay still, so in case it opens up, you don't flatten out. And then of course, the fibrosis issue, right? One of the biggest issues we face in any glaucoma surgery is the hallmark is what? Scarring and fibrosis. So, I don't want to deal with maculopathies and scar formations. That's not what I want to deal with. And I really do believe strongly in why I started using it many years ago was because I do believe the Molteno does address a lot of those issues. Now, of course, it's not perfect. There's no perfect procedure, but it does help at least decrease those chances. And how and why we'll talk about. And so one of the coolest things about the Molteno is that it is efficient surgery. It's a single quadrant. There's no muscle involvement, so you don't have to worry about dissecting the muscles and using muscle hooks. It's a very thin profile. And we'll talk about why it's important because the BLEB formation is an incredibly low profile. So not only for cosmesis, but from a fibrosis perspective, we tend to see less thick encapsulated BLEBs. But having a 0.4 millimeter kind of a contour thickness is really important as well. And I think in terms of like things like diplopia, we saw, you look at the different studies, the BB study, BAERVELDT, AHMED study, or even the TVT study, up to 15% have some type of diplopia. Double vision can be an issue, and you see not having to deal with the muscles. Now, it doesn't mean it's not going to happen, but it can decrease it by having no issue with muscle involvement. It comes in 2 sizes, and I love this. It's the fact it's a 185 millimeter squared, so it's a smaller plate than, let's say, the 250 BAERVELDT. But if you look at data, my friend Mahmoud Kiami and others have done some great studies comparing 250 versus 350 BAERVELDTs and showing no difference in efficacy. And so I think survival rates are the same. So I think for now, we're realizing that the plate size itself at a certain level there's no additional advantage getting it larger and larger. So I tend to use the 185. It's easy to handle, easy to fit into some of those small orbits and small eyes, and less dissection needed. And of course, you do have the ability to do the larger one, which is a 250 as well. But I think the 185 for me is what I've used a lot more. And we'll talk about the actual BLEB formation. This is what really, I think, as Joe is alluding to, the science behind the Molteno is this kind of 2-stage BLEB formation. There's something called a primary BLEB that we'll talk about, which is really kind of cool. So as you know, we tie our tubes off with our Vicals tie, or you have a ligation suture, whatever you want to use, and then a ripcord if you want to use it. But the key, what helps prevent a hypotenuse eye when that ligation suture opens up, is this concept of a primary BLEB formation. And this is what we'll talk about here. So with the Molteno, it has this kind of ridge. I don't know if you can see this ridge with my arrow here. That primary BLEB that forms is 25 millimeters squared. And what it does, when the BLEB forms, when the tie opens up, the ligation suture opens up, aqueous flows in and forms this initial primary BLEB around that small area there. And it does cause encapsulation, which happens to anything, right? Because aqueous is pro-inflammatory. When it forms that fibrotic kind of thicker capsule, Dr. Molteno loves to talk. I've had a chance to listen to some of his earlier interviews. He calls them death messengers. What happens is primary little BLEB is formed, causes fibrosis, cytokines are released, and pro-inflammatory mediators cause thick encapsulation, and then causes cells to die, right? Because when the cells die, what happens, it causes these death messengers, he calls them. What that does, it causes thinning. It actually causes collagen breakdown, some of these cytokines. And when it causes collagen breakdown, the posterior BLEB here, which is the back part of the plate here, forms a much lower, thinner wall BLEB that's much more porous. So you actually get a thinner, lower, longer term BLEB posterior to that primary plate. Now, why it's so important is because when that tube opens up, you don't get that sudden decompression of the eye, that hypotensive phase that we call when you get that kind of hypotenuse eye. We just don't see it with Molteno. That's a wonderful thing. At 6 to 8 weeks, I don't stress out and tell patients, don't move, don't do any exercise, sit at home and just watch TV, because this primary BLEB doesn't have the surface area to cause a sudden decompression of the eye. So that kind of 2-stage BLEB formation is what really makes this BLEB, this tube very unique. And this is some pictures showing you this idea of this 2-stage BLEB formation. So the primary BLEB area in the top here is what's formed when it opens up, and causing more laydown of collagen and fibrosis, of course. But then that happens is it causes then a thinning of the collagen by these releases of these death messengers, pro-apoptotic cells, that then allow a bottom here, in the bottom, a lower lying diffuse BLEB. So the BLEB actually looks much flatter than a lot of these blebs that I see from a BAERVELDT, or at least an AHMED for sure. You don't get that thick wall cystic bleb posterior to that initial plate. So I think that's one of the biggest benefits, and we'll talk about that as well. But I find that one thing you will have to notice is sometimes the IOP doesn't rise or doesn't fall and stayed low as quickly as, let's say, a BAERVELDT. So the one thing just to be aware of, let's say at 6 to 8 weeks, you expect that pressure to come down and be like 12 or 10 or 8 or whatever it is. This may take a little longer to come down. So don't be discouraged if at, like, say 2 months, it's still like at 18 or 20, and you're still on some aqueous hypotensive medications because of that primary bleb. So that's the one nuance and difference between, let's say, a BAERVELDT and a Molteno. By the way, show of hands or click, whatever, how many people here have used a Molteno in the past ever? Anybody here? I can't say anybody, no? You have? What do you think, George? Did you notice that same thing for you in your practice when you used to use it, that it was a bit longer to kind of come down?
I'm just too conservative that I put a ripcord in, so I control like when I pull it out. But I guess what you're telling me is you don't need to put that ripcord in with this device.
I do ligate it. I do ligate it. So yeah, I don't keep it fully open. In fact, there's some people that actually don't even use a ligation suture. Because that primary bleb, the formation, you don't get the flat chambers like you do with a BAERVELDT. I still wouldn't recommend it. I'm saying so everyone knows I would use a ligation suture. I use a 5.0 vicryl now, not a 7.0. I'll explain. But yeah, I don't use a ripcord. And then I think the 5.0 vicryl tends to open up a little faster than a 7.0 vicryl. And so therefore you kind of opens up a little faster. So I do think the pressures come down a little quicker than when I used a 7.0, but I don't use a ripcord anymore. How about you? What else? If you feel like it's nice to have that control to open it up when you need to? Have you had to open it up more often than not, or how do you use the ripcord?
You're talking to me?
Yeah.
Oh yeah. I usually tie like a 7.0 around a 3.0 proline ripcord, and then that usually dissolves. It's 4 to 6 weeks. So you see somewhat of a drop, but it's not drastic. Just like you, I like a controlled, step down on the IOP, and then I wait a little bit, and if it's starting to stabilize or go up, then I'll take out the ripcord. Then it drops down. And usually, because there's enough capsule formation at that point, it doesn't usually drop down to like 2 and the chamber flattens out. You'll get a little inflammatory response because you got this backwash going through the plate, but that's that's usually not a problem. So I guess it just basically, you're just saying this, the little ridge thing allows you to maybe not use a ripcord, which is nice because it, less hassle during the surgery and one less thing you have to do post-op.
Yeah, and what I've found is not using a ripcord. It's just easier from a surgical technique and then post-op. But right. More importantly, because I use a 5.0, so what I found is, and I used to use a 7.0. I know Gary Scheidegger saw me use a 7.0 vicryl, and I have a video where I actually severed it. So one thing we talked about, when you use a 7.0, you really tighten that. You can actually sever that tube, and Gary saw me do that. But recently I've been using the 5.0, and what's nice about the 5.0 is it tends to open up faster because it's not as small and tight, even though it's able to still occlude it. It tends to open up at like 4 to 6 weeks. So you kind of like within 4 weeks, you have the open patent system, but because that primary bleb is there, yeah, it doesn't come down like to 0 or come down like 6 or 8 or something like that, and kind of stays there, then climbs back up again. So I find that that's been really more efficient and has helped me not have to wait as long for it to open up as well. Anybody else curious? Just kind of what anyone else is doing out there in terms of ripcords, ligation sutures. What size sutures do you use to ligate, and if you use a ripcord, what kind of ripcord do you use? Anybody else want to comment? I know Chuck's on the line.
I just use a 7.0 vicryl. Can you hear me?
Yeah, I can hear you. What's up, Ben? How you doing?
Yeah, doing good. Yeah, I just use 7.0 vicryl.
Yeah,
nice and simple.
Yeah,
I tore off I ripped the tube a few weeks ago on a clear path, actually, tying a 7.0 vicryl too close to the plate, I think, and I just ripped the tube apart. So you're not the only one.
Yeah, it happens. So yeah, so I think the 5.0 is something to try if you guys haven't done it.
Yeah.
I think it works pretty well, actually, and so something to think about. But yeah, so the idea behind this primary bleb is that it allows you to prevent that hypotenuse flat chamber that we sometimes can get with BAERVELDTs as well. So in a nutshell, you're really trying to balance this equilibrium between formation of the bleb, so you have collagen deposition of pro-inflammatory mediators from the aqueous coming into the subconscious space, and the subtenon space. But then also because you have that rise in IOP, there's been multiple studies out there showing these releases of TGF, beta, and other cytokines that are released that do cause not only pro-inflammatory and fibrosis and collagen laydown, but then collagen breakdown and apoptosis. And it's that apoptosis and collagen breakdown that you see even in the AHMED, right? The hypertensive phase. And then what happens? It comes down. And that's the same principle, really, if you think about it, of what they're trying to do here. They're giving you a little AHMED valve kind of vibe in the beginning, that little small primary bleb, but then posteriorly is where it opens up. So it's that equilibrium, that balance between collagen deposition and collagen breakdown as well. Here's just a fun little video, just kind of a nice animation showing you this kind of concept of this bleb formation. And it's simple animation, but as you see that aqueous fluid flowing into the primary bleb, as you can see in a nice cross-sectional animation here, it increases this the bleb size. So you'll actually sometimes see a little ridge forming at a few weeks, about 4 to 6 weeks, when that ligation suture opens up. But then as it lays down collagen and you start to get fibrosis, then all of a sudden it opens up the posterior bleb with enough force, enough pressure has formed in that primary bleb, it will open up the posterior bleb. But by the time it opens up that posterior bleb here, you've had enough of these pro-apoptotic cells that are released that allow this posterior bleb to become thinner walled, which tends to have lower IOP and less encapsulation. And that's the premise behind it as well. So I was just gonna have some fun here and show you guys a quick video. We'll go along. We'll talk about data in a second here, but this is just one of my cases I did about a few weeks ago, and in a patient here with a failed trabeculectomy in the superior quadrant here. So I'm just, again, this is a review for a lot of you out there, so sorry if I'm boring you with my basic technique here, but a stay suture. This is a patient who had a failed trab here at the 12 o'clock position. So I'm in the left eye here, superior temporally here. I'm just gonna inject some lidocaine with epi. You know, I don't do any kind of blocks anymore. I just do a subconj injection. I don't even do a peribulbar injection. Just some lido with epi in the subconj space is really all we need now with these surgeries. And I just massage it there for hemostasis and to help loosen up the tissues. I make about a 2 clock hour peritomy here down, but I start about 4 millimeters behind the limbus actually, and because that bleb was there. And I'm a big fan of dissecting posteriorly, creating enough space. So I'm just gonna create a nice little opening here. And then posterior dissection, making sure I can get rid of all those kind of tenons, attachments, create enough space for that plate to sit here. So I'm pretty aggressive dissecting posteriorly. You know, again, you're not near the muscles, so you're not worried about hitting anything. There's nothing there except for bare sclera. So I'm just gonna make sure nothing's there, attachments. Then I'll actually use a curved Stevens scissors and just really stretch open that tissue there. Just will create that space here. Very important to grab tenons, not conjunctiva, and really kind of stretch it open. And I have a nice, significant open pocket posteriorly. Now here's that plate that we were talking about here. It has, first of all, I wanted to say, it's what's nice about it too is these anterior suture eyelets, which we'll talk about. It's much easier to suture, kind of like the clear path you were mentioning. It's nice anteriorly positioned, so it's easy access to those suture eyelets. But I always think it's important to prime the plate. So I'll take a 30 gauge or a 27 gauge cannula with BSS and just irrigate and make sure I have a nice patent system here and look for a nice bubble of fluid to form at the plate there, which you do see. And then now that I have it primed, you can see how it's kind of that curve. Now this curve is huge. This curvature here is crucial because this thing will suck to the sclera. The one thing I do not like about anything, whether it's a clear path or AHMED valve or even BAERVELDT sometimes, it just likes to ride forward. I don't know if you guys ever had that happen to you where you get it tucked back there, but there's posterior forces, a short eye, tight globe, and it just wants to keep riding forward. I can tell you with the Molteno, it just stays there because of this, with the polypropylene material and with the curved interface or curved contour, it just likes to hug the sclera wall beautifully. In fact, I've had situations where I couldn't even suture it down for different reasons. I just left it there, just put a little glue and I was done because it just stays so nice and tight. And there's those little anterior suture eyelets I was showing you there. So this thing fits in beautifully through a nice 2 o'clock hour conjunctival wound there, just nicely shove it down. I like to grab the suture eyelets, not the actual primary bleb. And look at that, just slides there and just hugs it. It just stays there. That to me is what saves the most time. You just bring it down there and I'm about 8 to 9 millimeters behind the limbus. You want to be about 8 or 9, I say. You can even be about 7 if you have to. But there you go, and it just stays there. So when you're suturing these things, the plate doesn't ride forward. You don't have to sit there and suture one and have an assistant hold the other side, keeping it down. So, and that's, I think, one of the biggest benefits of this plate is just the contour itself. And then, of course, you know, I do my ligation suture. This is a 5-0 Vicryl here that I'm doing, and I like to tie it in such a way where I'm not twisting it. What I used to do is I used to twist it like this a lot with my 7-0. That's where I used to find I was severing these tubes. And I know Gary saw me do one of those recently. So with this 5.0, I've realized it does a good job of occluding it. And I always test it afterwards to make sure it's occluded. But I find it opens up a little quicker than a 7.0. So that way you don't have to wait quite as long. And so that's why I'm not using a ripcord. You can see it's occluded. There's no fluid egress.
Are you aiming for 100% occlusion? Are you putting venting slits in, Paul?
I am. I'm doing venting slits anterior to the ligation suture, pretty much halfway in between the ligation suture and the limbus. So I'll do about 3 or 4 venting slits, which I'll show you in a second. But yeah, so I like to get some aqueous, I like to get some pressure control immediately, and that's how I do it. Just do a little bit cautery here, and then in this.
What did you sew the plate to the sclera with? Was that 8.0 nylon?
That was 9.0 nylon. So
9.0.
I use 9.0. What do you guys use? Anybody want to share what you use?
7.0 nylon.
7.0
nylon.
8.0 nylon. Okay. What else? Anybody out there want to share what you guys use?
Hey, Paul, just real quick reason. Why would someone use 7 or why do you use 9? Any particular reason?
I mean, just a strength, you know, you want to have it nice and strong. I mean, 10.0 is too thin, it'll break. 9.0 I found has worked well, but depends on the needle size. Some people like a little thicker nylon that they can manipulate. It's easier to handle larger sutures, but they all work. So there's no right or wrong. I mean, what do you guys think? Anybody else want to mention why you use your, so, you know, what do you think, George? Why do you use that?
They all dissolve if you wait long enough. You just don't want it to ride forward or slide back, you know, in the first few months, but.
Yeah. I mean, there's no right or wrong. I found the 9.0's always worked well. At Duke, we did that. But, you know, the one thing about this Molteno, I'm telling you, and I'm sure George can mention this too, account for this, it doesn't move. I mean, intraoperatively, this thing just suction cups to the eye with the material and the actual curvature and the thickness, the 0.4 millimeters, it really does stay there very well. So I'm not too worried about it migrating as much. But yeah, whatever, 8.0, 9.0, 7.0 nylon is fine. Now, I kind of make a little tunnel here. Sometimes I'll go in the sulcus depending on the cornea. Or if they're phakic or pseudophakic. A lot of times I'll go in the sulcus nowadays just to kind of avoid the cornea as much as possible. Because we all know that these tubes, no matter what you use, eventually we do see some endothelial cell loss as well. But I cut the tube in a bevel up fashion and just kind of nicely kind of pass it through that 23 gauge needle tract. And then once it's there, and then I'll put those venting slits in. I'll see if I can share. There we go. So what I use now, well, let me ask you guys, what do you guys use out there for your venting? Do you use a needle pass or do you use a blade? What do you guys do?
I use a 7.0 Vicryl needle.
Okay.
Just because it's there. I'm using it for the traction suture.
Nice, nice. That works. Absolutely. Anybody else have any comments? What do you guys use for your venting slits?
I've done it. I used to use this like super sharp blade, like looks like your video is about to show, but I've gone to the 7.0 Vicryl. I find that easier, just to pass the 7.0 Vicryl needle through the tube. You got to be more careful, I think, with the super sharp blade. Just make sure you go through the center of the tube. You know, if you go off a little bit to one side, you might not have the two perforations kind of opposite sides. They might be more toward the top or the bottom of the tube. I've never had a problem, but I think I'd like it probably more toward the left and right sides of the tube rather than more toward the top or bottom where it might get fibrosed off quicker.
Yeah, that's a good point. Absolutely. And you have to be careful with these super sharp blades here, the 15-degree blades, that if you go too far in, you can make it too big and you can sever the tube. So what I like to do, and so you have made a good point. That's a very good point. And when you do this, I like to go until I reach the other side. So right there, I reach the other side, then I come out. So I just go until I don't go all the way in until the end of the super sharp, just until the tip reaches the other side, then I come right back out. Personally, I found that I have pretty consistent IOP with that. You know, just the same every time. I do about 3 of these right in the middle of the tube between limbus and the plate itself. Then here I do 1 up there, and then I'm done. So sometimes I'll do more just if I want to be more aggressive, but 3 or 4. So, and then that's pretty much it. Then I'll go ahead and try to close it up. Now, what I've done recently, what do you guys do to cover your, I know, do people do flaps? Do you cover it? Do you do a long needle tract? What do you guys do for your covering of the tube?
I usually just cut a scleral flap so it saves money for my ASC, even though it's a pass-through now, but I'll use cornea too to pass. I mean, there's no studies that show that one's better than the other in terms of erosion rates. I don't know if anybody else feels differently.
And no, it's great points. Anybody else want to comment what they use to, do you use a flap or do you cover it with Tudoplast, cornea, sclera?
I use Tudoplast sclera. I like it. I just feel like it's thicker. I've used pericardium in the past. I felt that pericardium is too thin. I don't know. I don't know if it's some kind of immune response. I feel like a lot of these path grafts just kind of dissolve away, and after several years. And I've had some tube erosions over the years. So I've been doing a lot more tunneling. I just hate doing those tube erosion repairs, and I tunnel 5-6 millimeters back, and I still put a Tudoplast over just because I really want to minimize the chance for erosion. I don't know what the best way is. I think the tunneling might be the best way to go. Just doing a longer tunnel, getting away from the limbus with that tube. I think the closer you are to limbus, I think there's just more chance for erosion through the conjunctiva.
Totally agree with you. Yeah, I try to keep about 3 millimeters or so behind the limbus where I enter as much as I can. But I agree, a longer needle track, or to George's point, a nice scleral flap can work really well. If I don't do a scleral flap, which I've done recently, I'll cover it now. But the reason I asked this question is what I've done for the last few years now is using amniotic membrane to cover. And I've really found this to be cosmetically really appealing. We have not had any erosions. We actually presented some data back a few years ago at ASCRS. But it's just really nice because it's so quick. I don't suture them down. I just take a bunch of this. I use, I have no financial interest, but I use Ambio 5 for this because of the thickness. I do 3 of these pieces. I cut them beforehand, then I wet them so they become soft, and I just stack them together and put them right over the entire tube from the entrance to the plate itself. And I found that they just they have anti-inflammatory properties, anti-infective properties, and they have pro-growth factor properties, so helping with epithelialization. And so I put these 3 on there and just cover it. Now, the key to this too is I like to also cover tenons over this. So I just suture tenons over that amniotic membrane. So now I have amniotic membrane, then I have tenons covering that, and then I have the conjunctiva over that. So to me, this has really been a fantastic from a cosmesis perspective, especially those inferior temporal tubes where you really can see those things, and you just want to make sure you don't torture these patients with like a massive white blob there. And cornea sometimes I find can be pro-inflammatory. I don't know why, not inflammatory, but they can erode more. I've had a couple of erosions with cornea recently. So I've tended to go with the cornea, or rather with the flap, or I do these amniotic membrane. I found it to be really, again, really comfortable for patients and pretty fast. I just place it over there, don't suture it down, and just suture the tenons over that. And that's what they look like. So they look really nice. And you can't even tell sometimes you even had anything underneath there. And it does allow that to heal very nicely. And I've had some people with really thin conj where it really helped a great deal. So that's something to think about. If you guys have access to amniotic membrane, you may want to think about that in some of your patients.
Well, is there a benefit to using a clear graft in case you need to do a laser sutural lysis later on, or you'd actually be able to see where you're going?
Yeah, that's a good point, Gary. I mean, so a couple of things. To Gary's point, let's say you don't do a ripcord like George does, and you want to get that pressure control. Let's say your venting slits closed up or pressure's way up for some reason. It's nice to be able to do a laser sutural lysis. With this, actually, what happens, these amniotic membranes kind of dissolve after about 3 to 4 weeks, even less in some patients. So you have access to that with these or clear cornea. So that is a benefit there versus if you're using sclera or Tudoplast, you may not be able to see that suture. What you can do, what I have done, is done a needle pass. Let's say at 6 weeks or 4 weeks, it hasn't opened up and your pressure's going way up, your venting slits have closed up. You can just take a needle and go right through the conj, just go right through here in the slit lamp and create a nice needle pass and poke the tube. So I've done that where at the slit lamp, at like a month out, pressures went up to 30 or something like that. I just went ahead and took a needle, and you can't, it's a blind stick, but then you can see this tube in the anterior chamber move. So you pass a needle here and you just go and you're like, oh, I feel some resistance. And you can actually see this tube kind of move around a little bit. And you see, that means you know you've hit the tube, and just do a couple needle passes. And that might be enough for about a week or 2 to get the pressures down until it opens up as well. So that's what I've done too, Gary, if I can have access to the suture ligation.
What is that, a 27 gauge? You're using or a 30 gauge?
I use a 30, just a little thinner, in case especially, it depends on the conj. If I have a nice, thick, healthy T-nons and healthy conj, then I'll use a 27 gauge. But otherwise, a 30 if it's a thinner or light person, I'm more worried about any kind of leaks. But yeah, it works really well. Just enough to poke around blindly a couple times, and you can get enough IOP reduction for that first few weeks. So, and then of course,
Paul, what do these eyes look like a couple months out when you use the amniotic membrane? Like, is it just kind of melting the conj? What is it? Does it look like normal conj, or is it thick? Is it T-nons looking, or what does it look like?
Hey, Joe and Kate, do you mind if I show a different deck real quick? Is that cool? All right. Sorry, yes. I'm going to show you some pictures. I'm glad you asked that question. I have a picture here, what they look like. Here we go. So this is, let me just stop sharing and share a different deck real quick here, guys. 1 second here. This is an older slide deck I had a while ago here, just showing that, this is what it looks like. Now, this looks scary. This you see this kind of exposed tube here on the right? This is a patient with very thin conj, no T-nons at all. No T-nons at all. And you can even see how thin, you can see the sclera right there, just super thin. This is actually 3 years later, and it looks really quiet. And so what I've been fooled and really surprised is that you see almost like you're like, oh shit, is this gonna expose? And it doesn't. So it really is a nice kind of cosmesis there. Majority of people who have healthy T-nons, like you saw in that video, it'll look like healthy conj. You won't see the tube at all, and it just looks like healthy normal tissue. But it's a very quiet conjunctiva. That's the one thing I've seen. So that's what they look like, even without any T-nons and with no covering except for a couple what do you call it? Amniotic membrane. You can see here too. This is right there. You see this almost like this little epithelial layer here. That's what it looks like. You see this little thin epithelial layer that formed. This is years after, which is just enough to keep it from eroding and calm the pro-inflammatory mediators that cause the erosion. And so that's what's been really, I think, beneficial. And it's nice to how it looks. These are just some videos I showed using amniotic membrane to help a BLEB leak, but that's a different lecture. But does that help, George?
Yeah, so you think it's the inflammation that causes erosion, or isn't it like the eyelid rubbing or people rubbing their eyes? I mean, it's because what you just showed, that's kind of like the end appearance, almost like no matter what you do, because everything melts away and you're left with this layer of conj, and you pray to God, it looks thin, it's not leaking, it's still there, and you just pray, you're just praying like, please don't rub your eye, please don't, erode. But it's interesting. Yeah, no, I mean, I think you're absolutely right. What I would say is that, as you saw in the last one, as you saw, it does look very thin, but there is a epithelial layer that forms just enough to prevent that from happening. So the difference between one that you're like, oh my God, I got to see every month because it's going to erode any minute and I have to take it to the OR, versus one of these is that you see this kind of this grayish thin layer that you saw there in a high mag, which is what I found has prevented from those erosions. Again, I'm not gonna sit here and say nothing can happen, of course, you know that. Yeah. But compared to pseudoplast or cornea or anything else, we haven't seen any increase, and the cosmesis has been so nice, and it's much quicker, and it's a flatter, the profile of these are just so low that it works well, and especially if you don't have good T-nons, I have found that's what really has benefited as well, because you really wanna have that kind of protection, so that's been helpful. So. Hey, let me go a little sideways, and so what do you use if you have a tube erosion? How do you fix it? It depends on how much healthy conj I have around it. Either do a flap of conj over it, or I'll cover it back up with some, either amniotic or pseudoplast or something else. Or I'll tuck, if I can, I'll put it in the sulcus. I'll go back if it's a pseudophakic patient, close it up, put it further back, and then try to do like a flap if I can, of sclera. Just depends on the tissue. What about you? What do you do? Like if you're really short on conj, let's say it's like huge erosion, and there's scarring and you just can't mobilize conj. You've got this big hole. Would you use amniotic membrane? I have done it, absolutely. Will it be enough? If you don't have, if it's just amniotic membrane without conj over it, it won't be enough. No. Right. Yeah. So what I do, this is reported, and this is kind of like my go-to now. I don't even bother with amniotic membrane. Is I use a buccal mucosal graft. Oh, so okay, sure. I'm like an oral surgeon, so I just harvest this big ass piece of mucosa from the inner lip, and you just numb it up. I use a chalazion clamp to flip the lip. I infiltrate it with lidocaine. I just take a corneal tree fine, whatever you need, like 8 millimeter, 10 millimeter, just punch it out, trim it, You have this big old wad of this it looks like snot actually when you take it off, and then just sew it right over the hole. And it's amazing. It's like this amniotic membrane stuff the body recognizes as it is native tissue, and 2 months later it looks like the healthiest, thickest conch. I don't think I've had any re-erosions, like maybe one. Like, it's amazing, you know, what the body can do.
No, that's great, man. Thanks for that advice. Yeah, I mean, what I have done is I've done autograft. I've done like a autologous conj graft where I've taken, let's say, inferior nasal conj and brought that up and done that. But I think what you're saying, if you have nowhere else and no other conj anywhere in the eye, that's a great idea. I haven't done that yet.
And it's cheap. You know, it costs nothing. You got tons, and the incision in the lip, you know, heals like in like less than a week. You know,
I can imagine. I mean, for the lip, it's like a little dot.
Exactly.
You know, compared to the eye. Oh, it's great. Thanks for that work. This is why I love these events, man. We need more of this stuff, you know? So I appreciate that. Any other thoughts from anybody else? Any comments, questions so far about the techniques and your techniques, and you want to add to help out? All right. Cool. Well, please feel free. Thanks for all that advice. I'm just going to show you a quick question. By the way, when you guys ligate your tubes, do you do it at the table beforehand pre-op, or do you do it like when you're scrubbing in, or do you do it when it's already sewn in to the eye? What do you do?
If I have a fellow, I let the fellow do it.
What about me who doesn't have a fellow? What do you do?
I know, right? Yeah. I like to do it. I've done it both ways. I don't know. I think it's easier when it's already like sewn in, you know, because it's stable. You know, it's on the field. You don't have to worry about, you know, slipping off the field. But, you know, I think it's either way. I don't know. And my only trick sometimes is I'll tie the knot. If the conj is really thin, like sometimes I'll tie the knot so it's underneath the tube. So I tie it behind. And sometimes if it's vicryl, I'll mark it with some ink. So I think if you do that, maybe when you cut it with a laser, it takes up the laser energy as opposed to using nylon. Like, I still like the vicryl, but sometimes it's harder to cut it with a laser unless it's inked.
Yeah, it's very thick. It's hard to cut. No, absolutely. Yeah, I've tended to tie it off when it's already sewn in, just it stays there. It's easier for me. And actually, what I've done recently when I'm actually tying these sutures now, Arsham Shabani taught me this great tool, a technique where you tie it up, you pass the suture here, then pass it here, and then tie it. So that way they're both tied together, so it keeps it stable versus tying one off and this is kind of slipping back. Although I don't know how to do that with the Molteno as much because it just stays, like I said, where you sit down because of the curvature. But this is just a quick video just to show you of, I think, Gary, you were here for this one. I don't know if Gary's on the line still, but do you remember this one, Gary? This is the one where I severed it. So don't do that. Don't do this and this at the 7.0. That's when I found I had the highest risk of causing it to sever. So I thought I'm all good here. And this is, you know, I'm like, oh, sweet, let's just test it to make sure. And I'm like, let's just test it here. I'm like, Gary, this is just formality. Let's just test it just to make sure it's occluded. And I'm like, blah, 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 blah. And then all of a sudden I'm like, oh, wait a minute. There's a leak. Gary, I think you're muted, Gary. Gary, I think you're muted, buddy.
Ironically, I asked Dr. Singh before the case, can you cut through with 7.0? He said, no, the suture would probably break before it would cut the tube. So I was the bad luck charm that day.
Yeah, I know. I was like, oh man. So I was using 7.0 for, as Gary knows, right? I was using 7.0 for everything. And I was like, oh, I did sever that thing. Dang. So yeah, I think the key is this. Just want to pull with opposite forces, but the twisting motion is what I think is where you get in trouble. So just want to show you that that can happen and why it can happen. And here's just me now with a 5.0. Just put this is a 7.0 in this case again. But it's
better to do that before you stick it and sew it into the eye.
That's the reason. But that's the reason why. Exactly.
Yeah, right.
Good point.
That is the reason why you do it beforehand, is to make sure you don't waste your time. Exactly right. So, but with the 5.0, I found a little bit less chance of that happening now. And you want to pull it straight across versus twisting it. So something to think about there. All right. Well, great discussion, guys. Keep it up. And just to give you some more information on the Molteno itself, and we'll talk about some data too, of course. But bottom line, you have the 185, you have the 245, and then you have the pediatric one, which is 80 millimeters squared. So I use the 185, I think, for almost everybody. Anybody, George, or anyone else who's used it? Do you guys use a 245 ever?
I think I've used both.
Any reason why? Use which one?
I think maybe I wanted a slightly lower pressure. I don't know. I'm used to 250. 250 is like my go-to for BAERVELDT and ClearPath. So maybe that I'm just a creature of habit.
Yeah, no, totally cool, man. But yeah, the 185 I found is it's they both work very well, and they're both single quadrant. No need for isolating the muscles. But for me, I've used the 185. But yeah, exactly right. If you're comfortable with the 250 barbell, you want that same size, they have an option there, or the 185, which is like which is a little smaller, like the AHMED kind of size valve. A little bit about data, just so you guys are aware, there are some data sets out there, and just we'll go through some of these real quick. But there's some really amazing results, actually. Here's a study looking at just a retrospective review, 106 eyes, 97 patients. Pretty sick eyes, actually. This is primary surgery for a tube, but it was actually, and not just really healthy eyes. Some of these had really unhealthy conj and some neovascular glaucoma, uveitic glaucoma, some pseudoexfoliation as well. And about a 7-year time frame, about at least 1 year follow-up. And the defined failure is pressures greater than 21, less than 20%, or less than 5 mmHg additional reduction at 2 consecutive visits. So at 3-month follow-up. And they found about a 94% success rate at 1 year as well. And you can just see the curve here, about 91% success rate at here. This is actually it was 94 at one year, and I think it was at 3 years at 91%. If you look at the medication burden, what you expect, these patients are on 3 or 4 meds on average when you have these sick eyes, and down to about 1.3. Pressure down to 14. So pretty really good results here with the Molteno. And this is the 185, not 175, 185 Molteno. So again, with the 185, you get really good results. Here's another one comparing Molteno to a trab, and of course, trabs work very well, but there's failure rates with trabs in a lot of these studies. And you look here, comparing the two, baseline pressure is very similar at 10 years, 20-year follow-ups. This is pretty ridiculous in terms of follow-up, but you're getting that lower teens, the 13, 14 range. Both seem to do very well and pretty equally efficacious, and even mean medication reduction was very similar between the two groups. So really, I think it's the bottom line, it's going to work very well. That's really what we're seeing here compared to what we see with most other glaucoma tube surgeries. Compared to the barbell, which is, I think, the most important kind of comparison, which is our quote-unquote gold standard. You see here, there's comparisons both between the 250 and 350 barbell, using the 185 and the 245 Molteno. And what you find is both work very well. The post-op IOP is very similar between the Molteno and the barbell. And what you find, though, is this improvement in time. You look at 15 minutes savings in time between the Molteno versus the 350, just because of the size of the barbell. But even with the 250, you see a significant about 5 minutes of savings in time. So more efficiency. We also look at hypotony rates, and you see that there's a little less hypotony rates and flat chamber rates with the Molteno as well, which is not in this slide, but you do see less risk of hypotony or maculopathy and those kind of issues that you face as well. Again, just another comparative barbell as well, showing you same idea, medication burden reduction, IOP reduction, very similar. In this case, slightly better with the barbell in this case, but around 30-40% reduction with half the medications that you see. And so a lot of these are sick eyes, patients who definitely have a lot of secondary surgeries a lot of times. But the key is no muscle manipulation, more efficiency, and less post-op issues such as hypotony and flat chambers. I mean, that's the biggest thing that I found where the biggest advantage was the barbell. The barbell works great, but you have those other issues that we face as well. And of course, the AHMED, I'm not sure anybody here use the AHMED, the FP7 as another tube. You guys use the valves, tubes, or drainage devices? When do you use the AHMEDs? Anyone want to comment on when you use like a valved procedure like an AHMED versus a non-valve, like a BAERVELDT or Molteno? Anyone want to comment on when you use what? How about you, Chuck? When do you use an AHMED FP7?
I use FP7 when I want like a quick pressure reduction, mainly just my neovascular glaucomas. I don't completely trust the venting slits on a non-valved implant that's have the tube ligated, that I can trust that there's going to be drainage to the venting slits before that ligature suture dissolves. So it's mainly the neovascular glaucomas. Anyone that can tolerate a higher pressure, slightly higher pressure, I'll go with a non-valved implant.
Makes sense. Absolutely. Yes, I think it's similar to me. If it's really quiescent uveitic glaucoma where it's kind of stabilized, not actually inflamed, and they're just on multiple drops and they have time, I will put a non-valved plate. But yeah, if their pressure's like 45 or 55 and they're inflamed, and I'll put an AHMED. They'll fail anyways eventually, but at least they fibrose anyways. But no, I agree with you. Anyone else? George, what about you, man? What do you do for choosing between a valved and non-valved? Oh, you're on mute, buddy. Uh-oh, I think you're still on mute.
Yeah, if
Oh, there
I
we go.
get the pressure down really quickly, you know, in a neovascular, I'll use an AHMED, but otherwise it's pretty much non-valved.
Yeah, I'm with you. Absolutely. And you know, there's the AHMED versus BAERVELDT study, which also showed that, you know, both were very good, but you had higher fibrosis rates, higher hypertensive phase rates with the AHMED. And that's just because when you have immediate release of aqueous into the subconch space, what we talked about earlier, you get this fibroblastic growth, and that causes scarring. But the problem is,
What's that?
with AHMED, you don't have a posterior plate.
Oh yeah, sorry, I got the alert.
So that was the reason why you see this fibrosis in this hypertensive phase, and it should thin out. And the whole premise behind why the AHMED pressure does come down eventually is because the same principle we talked about with the Molteno, which is that whole kind of apoptosis, thinning out of the fibrosis of the plate itself. But in some people, it's irreversible. That's the problem with the AHMED. Those people who have those hypertensive phases, they just kind of stay there. And so for me, I'm super aggressive with aqueous suppressants with an AHMED, especially. Now, what I'll do is I'll put them on aqueous suppressants. If their pressure is 8, I'm still keeping them on a COSOPT or a Comagan or something. I'm keeping them low as much as possible, because I want to protect from that hypertensive phase and also protect from that thick cystic BLEB that can form. Because once it forms, it's really hard to thin out, although it can, it's just not as easy as well. And so that's the idea. And if you look here, same kind of findings you see with the Molteno versus the AHMED. At 24 months, you see a better efficacy statistically significant between the Molteno and AHMED as well. And you know, you look at the mean medications, slightly higher with the Molteno in this case here, but both very similar as well. So I think what the key in this study showed you though also is that you had less hypertensive phase with the Molteno in this study as well. So I think that's where the benefits come in, is the hypertensive phase is an issue with the AHMED, and less chance of fibrosis overall in general. And again, this is the same thing with the AHMED BAERVELDT study, which I just shared with you as well. 80% failure rate in the AHMED versus 53% in the BAERVELDT. And that's, again, that hypertensive phase. But both had really good efficacy overall, though, in general. So I think these plates work well. It's just a matter of what do you want to deal with. Surgical time, hypotony post-op, and what does a BLEB look like in the future? Those are 3 characteristics of a BLEB and a plate that we want to deal with. And that's kind of where I think the Molteno fits in. Last couple slides, I want to kind of open it up. By the way, anybody have any advice on kind of how do you use topical antihypertensives post-op with your BAERVELDTs or Moltenos? What do you do in terms of how low do you keep the pressures, and how do you control IOP besides the venting slits and the ripcord? Are you aggressive keeping the pressures down even if the
I think if you got a high pressure, you got to be aggressive until that ligation suture dissolves. You know, that's the tough part, you know, putting the patient on those drops, and sometimes you have to use Diamox, you know. I mean, you're just trying to delay opening up the ripcord for as long as possible, but sometimes, you know, your hand's forced.
Yeah, you know, a funny thing. So Lou Cantor, I don't know if you guys know Lou Cantor from Indiana. So he was just funny because when I first came out of fellowship, you know, Lou's like, "Hey man, give me a call anytime you have any problems. I'm in Indiana, you're in Wisconsin, not too far away." I'm like, "All right." So I called like a week after my first, like, you know, private practice surgery, and you know, I pulled the ripcord a little too early in a BAERVELDT, and pressure was like, you know, 0, and I freaked out. I'm like, "Oh my God, what do we do? What do we do?" I'm gonna call my, you know, Lou Cantor. He's like, "Why are you calling me? Just fill them up with some viscoelastic." And he's like, "That's what I do." You know, Lou doesn't even tie a ripcord at all, or tie a ligation suture. He just leaves it open and has his fellows come in every other day to fill viscoelastic till the BLEB forms or till the plate fibrosis occurs. So, you know, again, you have to do some of those kind of funky things as well. But yeah, I think Diamox is important. I'll try to puncture the holes as well. But I think it's really important to keep them on, you know, aqueous suppressants as much as possible, like really early on, and that does help when it does open up. You have to stop it though, because then what happens is you tend to get sudden decompression in those BAERVELDTs. That's the one benefit in the Molteno, because when you have aqueous suppressants or Diamox and you have decrease in aqueous production like that, and when the BAERVELDT opens up and you have this sudden egress of fluid, but you're not having enough aqueous production, that's where you get that chronic hypotony. And that's one of the biggest reasons why I switched over to Moltenos, because, you know, if I put them on Diamox to keep controlled, when it opened up, I didn't get that flat chamber like I would get with the barbells. That was a big issue that I used to face. A little bit about the makeup, the chemical makeup of the plate. You know, there's different plate, obviously silicone, polypropylene, and other things that you can use as well. And what's nice is if you look at some in vitro studies on kind of cell plate fibrosis and adhesion and these radio labeled markers, and they found with these radio labeled cells, epithelial cells, you find that there's cell adhesion greater in the AHMED plate, the silicone plate, versus the BAERVELDT had much less. And then really the Molteno out of all three had the least amount of kind of fibrotic attachments of cells to the plate. Again, it doesn't mean that no fibrosis occurs, of course, but it wasn't as aggressive as the AHMED or the BAERVELDT. Although BAERVELDT and Molteno are very similar, there was a slight tendency to have less cell adhesion with the Molteno. So there, again, that's another potential benefit, again, of the type of fibrosis, the type of kind of encapsulation that forms compared to the BAERVELDT. So really at the end of the day, you know, one of the biggest things, just kind of wrap it up, you know, I think they're all good. And it's just a matter of what are you willing to deal with? It's not that they're not going to work. It's just, do you want to deal with hypotony? Do you want to deal with, you know, efficiency of surgery? Those kind of things. You just have less chance in this plate. But I really think there's a lot of science, and you're going to see more. I know Nova Eye is working a lot on the data, on trying to really show what does this mean with the primary BLEB and that death messengers and apoptosis and that thinner wall BLEB. So they're doing a lot of research around trying to show that is a benefit there. But that primary BLEB, I think, is really one of the biggest differentiators of this plate. And so I think it's the best of both worlds. To me, I think it blends the best of a valved surgery in terms of efficiency and technique with having a single quadrant, as well as it allows us not to have to worry about the rectus muscles, very easy to implant. But again, this whole avoiding hypotony issues with a thinner wall BLEB with a lower profile, I think is really what's been helpful to me long-term for a lot of these patients, especially if you're using inferior plates, inferior tubes, really can make a big difference from the cosmesis as well. So thank you so much. I wanted to open up to any more questions. These are my kids from many, many years ago. Hopefully one day we'll have better solutions for glaucoma than what we have to do now. But those are my three kids. But anyway, thanks guys. I hope that was informative, but you know, I'd love to open it up to you guys having any questions, any comments on what we talked about tonight.
Hey, what do you think about mitomycin and AHMEDs?
You know, there's a
UCSF study.
Yeah, I was saying there's a recent study. I still don't know if I would still utilize it. I think there's still more risk of exposure, man. I mean, I don't know. I still don't want, I'm not yet ready yet to use it on my routine cases, just because there's probably more risk of exposure and thinning than there is from the benefits. But what do you think?
I mean, it was a pretty well-designed trial.
Yeah.
You know, it was San Francisco, I think, China and Mexico City, so a lot of non-Caucasians. So I mean, the funny thing is, when I was in Arkansas, man, I was an awesome glaucoma surgeon, and everything worked. You know, my AHMEDs worked.
No one has tenons.
No one's got tenons. Like, man, this is awesome. Like, it's probably the same in Wisconsin. I'm back here in Oakland. I'm like, oh my God, you know. So I think it's interesting because you know, the way I you know, and Jeff Freeman loves this tube. I don't know if you know Jeff.
Yeah,
He's in New York.
definitely.
So
Sure.
I've talked to him many times at meetings, and he's always like pushing me to do this. And he's like, yeah, you know, I know you like to do the super tenons thing and you're African Americans. This is like perfect for that. Have you done that? Do you see a lot of African American glaucoma?
I do, man. In fact,
Do you
today,
really?
today I had to do a trab on an African American, which will probably fail in about 6 months, and I'll do a tube. So,
Right.
but yeah, man, I do see them. So, do you think the super? I mean, there were some studies that didn't really make a difference, but do you feel like the super tenons helps you in those patients?
I think so. I mean, I've done a bunch, and you know, you got to make sure they have good conj, but
Yeah.
it's nice to have a tube that doesn't have a huge ridge, you know, fits the contour of the globe, you know, I mean, and then, you know, ClearPath has some advantages there. I think this, you know, the Molteno3 has some advantages there. I think they both are better than a BAERVELDT, although I put in just a ton of super tenons BAERVELDTs. And I know, I think I just need more experience with it, but I would never do that in a Caucasian.
Yeah,
You know,
yeah, I agree. If you have a super thick conj and tenons, you can do a lot more. You have more flexibility to do whatever you want with. Actually, it's kind of nice. But yeah, I mean, look, I use a clear path to be fair and balanced. I've used it a bunch too, and I've learned a lot about it. I think it's a good plate too. I think the benefits of it being a very flexible, malleable plate. I have a nice video of me tacoing it into the eye. So I think it's a great option.
yeah, I love that. I love that video.
Thanks, man.
I love
No,
that,
it's
man.
fun. And that's the thing with these two new plates. I think we're seeing a lot more excitement around plates and tubes. I will say though, and I told this to those other guys, from a profile perspective, this is still the best profile. I mean, I love the small incision technique that I use with that. So if I have really, unhealthy conj, sometimes I'll try to use that small incision technique to minimize the amount of cutting. But in terms of just the profile, this thing sticks to you without, you don't have to even suture this. I'm not saying don't do it. I know Kate and Joe will kill me, but honestly, I've done it where I haven't even sutured it. I just suction cup there and just put the tube in and it doesn't move. So, I mean, that is really the coolest thing about it. And I think the primary BLEB part of what we talked about, but they're all good. And it's just a matter of having more experience with all of them and kind of gauging for yourself what works best.
So if you throw it on top of tenons, it may not suction as well, do you think? Or is it going to
know.
slide around a little bit more? Or
That's a great question, man. I don't know if I have enough data to. That's a good point. Let me know. Seriously, try it. I mean, I would say it probably would not suction cup as much, but then conj or tenons is going to suction cup around it and allow it to kind of stick down. It's the curvature, not just the actual suction, but the curvature.
right.
So it's still going to probably stick there as it's going to be as tight, maybe not, but something to try. I'd love to, hear your thoughts when you try it.
Okay.
Good question. Awesome, man. Anybody else? I know anyone else got any questions? Anyone from Nova Eye? Do you have any questions for all of us? I know Chuck and George, we all kind of give you some thoughts.
Dr. Tanaka, can you hear me?
Yes.
I used to be your canaloplasty rep years ago. How did
Yes.
you leave beautiful Fayetteville, Arkansas for San Francisco?
I know. It was
I don't
the
blame you.
Chinese food there was amazing. I don't know how I left. Yeah, no, it was COVID, man. COVID's ruined a lot of stuff. So
Yeah, that's true.
the bottom line. Yeah, but it's good to be back.
You had Walmart right there.
I know. There we go. No,
Yeah,
I enjoyed my time. I really did. I had a great time. Steve and we rocked it out. It was great.
Good.
Learned a lot, but it's good to be close to family.
Good.
Yeah.
Good for you.
Yeah, no, man, it's important, man. More and more I realize it as I get older in life. I feel old now. It is so important. You got to balance life, dude.
Yeah.
It's so hard to do it. But
I have a quick question. So when you're inserting the tube into the AC, some doctors prefer a 22 gauge versus a 23 gauge. Are there any advantages for either one of those?
22, I'll give you my thoughts. I'd love to hear George and Chuck, whoever else wants to chime in. 22 gauge is going to be easier to slip it through, no doubt about it. But you might get peritubular flow, so you may have more risk of hypotony and uncontrolled pressures being too low. Rather, I like the 23 gauge because it's really tight and it fits in nicely. I think if you just cut it with a bevel up fashion, you create enough of a groove there. It's not too hard to fit it through. So I use a 23, and what I do when I enter in, I do twist it though. So I'll enter, as you saw there, I'll just kind of twist it once and come out. That opens up a little bit more. So it's like a 22 and a half, so to speak. But what about you guys, Chuck and George?
I like a 23. I like the twist idea. The other thing I do is when I come out, as I'm just coming out with the bevel, then I'll do a little side swipe to create kind of a funnel. And so that way when you're feeding the tube and it kind of is easier to go in. And once you're in, if you're in the track, it'll just slip right in. But I like the snug fit, just like Paul.
Good.
Yeah. What about you, Chuck? What are you doing, man? You do 22 or 23?
I've always been a 23 gauge guy. I just want to, I don't want that extra flow around the tube, that peritubular flow you talk about. I think if you cut a good bevel on the tube, it just slips right in. And I don't know the name of it. I have these like forceps. It's got a little notch on it.
The tube.
I think it might be by the IMPLANT people, but it's got like a little angle forcep, and it has like a little notch that kind of grabs right around the tube. I mean, you get perfect grip on the tube, and you can just slide it right through your 23 gauge needle track.
Yeah.
But really the bevel on your cut, a long bevel, it just slides right in. I mean, I know a lot of people have problems and go with the 22 gauge, but I think if you cut a long bevel on the tip of the tube, 23 gauge is no problem. So I don't know.
And what do you guys do? I'm sorry, if you guys don't mind from Nova, I'm just gonna ask questions because I want to learn from my friends. So I'm just gonna keep asking questions. If you guys want to stop anytime, let me know. But what do you guys do for someone who has a, let's say an RD and had a buckle in place? And let's say you were surprised you didn't realize it. It's happened. But no, seriously, what do you guys do for buckles? Because I know that's where I like this, the profile of this. But have you used BAERVELDT, or have you used the Molteno in those cases? Obviously, it's an issue sometimes when it's trying to dissect underneath that. Do you shock it tubes? What do you do?
I've trimmed BAERVELDTs, just chopped them up to fit. I mean, if you've got a really anterior buckle, gosh, that's hard. You know, you're not gonna be able to put much in there. I mean, you could truncate it to like a little tiny little rectangular plate, but I just don't know how effective that's gonna be. Have you ever slid a clear path or something over it? I think I've done that maybe once.
I've actually not a clear path, but I've slipped actually a Molteno over it and one underneath it. But I've also done a shock it too, where just kind of put it underneath there because like use the capsule of the belt, and you just basically go ahead and use that as your plate. But yeah, I was just curious because it's happened a couple times to see what other else is doing. No right or wrong. I'm just curious.
Yeah, those are tough cases.
Yeah, those are tough cases, no doubt. So where do you like to, when you put your tubes in, do you ever curve it to come in at 12 o'clock or 6 o'clock inferiorly? Or do you just go straight in?
I used to go straight in, but recently I've curved it over towards 12. I just think the erosion zone is right supratemporal, you know, based on where the eyelid lays. So if I curve it, I feel like it's not gonna hit that eyelid.
Yeah, I agree with you. I used to go straight in like that, another one, but nowadays I've seen that it's just a little bit nicer to have it protected by the eyelid. Absolutely. Cool. Well, any other questions, any thoughts? Anybody else? This was a lot of fun, man. Loved hanging out.
Yeah.
I know it's getting late. It's already been an hour, so I want to be respectful of everyone's time.
One more quick question. So I've heard of some that have actually sutured the tube to the sclera. Have any of you ever done that when you're ligating the tube?
I do it routinely. I think if you have a tube that's riding up against whatever you've covered it with, whether it's a graft or a flap, I feel like that friction from the posterior aspect is going to contribute to a tube erosion. So I like to have it flat and maybe even tent up whatever to create a little bit of space. I don't know if that's going to help. Theoretically, it sounds good. And it doesn't take like too much more time. So I take a 10-0 and I just sew it.
The reason behind this surgeon's method was that he can control the length of the tube in the AC by suturing it to the sclera. So he preferred not to suture the plate, but he used the ligation suture of the tube on the sclera to control the length of the tube. And plus, I'm assuming by suturing it to the sclera, the plate would not migrate.
Yeah, I mean, look, at the end of the day, after a few weeks, about a month or so, when that thing opens up, you've had enough fibrosis, it's not going anywhere most likely. So I agree, you probably don't have to suture the plate, especially I mean, again, going back to the Molteno, it doesn't move in general. But I think to George's point too, is what's nice about that, especially like an AHMED FE7, you have like a ridge there and then it comes down, right? That kind of that slope there, you want to flatten that out. So that way it's not rubbing against. So from that perspective, I think there's a benefit to doing to suturing the tube. So I'll suture the tube if it's not a flat profile. But to your point, I think, yeah, Mike, you could just suture that down and just let it stay there. And then eventually, even when it dissolves, it's probably enough fibrosis, it's not going to move again.
Got it.
Yeah, I guess it's a good question.
Great tips.
Yeah.
All right, everybody. Well, thank you very much. Unless if there's any more questions, we'll take them. But Dr. Singh, wonderful job for the first one, kicking it off. This was fun and entertaining, and also great educational evening. So thank you very much for putting this on.
Thanks,
guys.
Everybody. It was a lot of fun, man. Good luck with everybody. Stay safe and healthy.
Yeah.
Great job, everybody.
Thank
you very much.
Oh.
Bye-bye.
Thank you, Dr. Paul.
Good job,
Way
Paul.
better TV than the town halls tonight.
Yeah, man. That's right. I got to go back and see what's going on now.
Didn't miss much.
There's nothing going on.
Awesome. Thanks again.
Everybody.
Thank you. Thanks,
Thank you,
everybody.
Thank you. Good evening.
Bye-bye.